Clicker.
And the little thing is the,
Oh, yeah.
the little middle
clicker. This. Okay,
Forward,
fine.
backward.
Clicker.
Good.
Okay. So I'm going to start at the beginning because there's people here that are newly diagnosed that may not, know all the lingo. So I'm going to start at the beginning and give people some vocabulary, and then we're going to go all the way from the beginning today to the end, or to the more recent of what clinical trials are happening right now and where are we going in terms of new treatments. And as many of you know, I'm kind of a refugee from UCLA. I was at UCLA for 25 years, and I've come to Orange County as of January to be at UC Irvine. And I'm very pleased that almost everybody, with the exception of Ben, who is also a refugee of UCLA, who many of you know, are from UCI. So you can kind of see how people work as a multidisciplinary team, because that's really what it takes. So I was kind of channeling Emerson, but it's the same thing that Susan was saying, is that if you know something, then you have more power, right? You can participate more in your care, and you can make better choices for yourself. So I said I'm really going to start at the beginning, and I mean that, and let me figure out how this won't go in and out. So a lymphoma in general, because there's people here that are interested in B-cell lymphomas and some that are interested in T-cell lymphomas. A lymphoma is a cancer that comes from a cell called a lymphocyte. And a lymphocyte is part of our immune system. They are blood cells. They come in two varieties, T like in Tom and B like in boy. And those different cells have different roles in the body. So all of our cells start off from a mother cell. It's called the stem cell. You may have heard of stem cell transplants. Those are cells that are collected and utilized to reconstitute somebody's blood production in their bone marrow. And the stem cell decides it's either going to be a lymphocyte or it's going to be myeloid cells, which are other kinds of white blood cells. And then it further decides between a B cell, a T cell, and something called a natural killer cell. And so lymphomas happen when one of these lymphocytes gets a little nuts, it forgets what it's supposed to be doing, and it just starts generating copies of itself over and over and over again. It's a clone of the same cell. So B-cell lymphomas originate from some B lymphocyte back in the day, and T-cell lymphomas originate from some T lymphocyte. Now in the US, if we look at all the lymphomas, and there's more than 70 kinds of lymphoma now, if you can believe that, and we're just going to look at a portion of them. The majority happen to be B-cell lymphomas in the US, hence our kind of role as the orphan in the lymphoma world, because T-cell lymphomas just aren't very common in the US. They're more common in other parts of the world. So it's not the same in different countries, but in the US and in the UK and industrialized countries, most lymphomas are B-cell lymphomas. Now, the flip side is that when you look at just lymphomas of the skin, most of them are T-cell lymphomas. And that's a little bit related to how the cells function. So this is our whole lymphatic system. And you see the green here is the lymphatic system, and the little beads are lymph nodes. So that's kind of where B cells reside. They reside in lymph nodes usually, and they pretty much stay put. But T cells are really different. They're floating around. They float around in the blood. They go through the lymph nodes. They go through the lymphatics, the little connections between the beads here, and their role is kind of like as if you hired a surveillance company to surveil your house. That's their role. They go around in the blood. There's a specific group of them that's responsible for the skin, and those are the guys that cause mycosis fungoides. They go in the skin, they go in the blood, then they go back to the lymph node, and if they have something to report, they have a means with which to stimulate B lymphocytes to get into the act. So the whole immune system functions in concert. So the immune system is a very complicated thing. Some of it related to lymphocytes, but there's even more parts to it, which maybe you guys might touch on a little bit, I don't know. this all kind of works in concert, and sadly, when one of these cells goes awry, it still remembers a little bit of what it was supposed to do, but it can't really function normally anymore. So most B-cell lymphomas are in lymph nodes, although they can be in skin, which is why there are people here today interested in B-cell lymphomas. And most T-cell lymphomas are not always in lymph nodes. They may be in skin. There's one that just forms in people's noses, if you can believe that. There's one that forms in people's intestines. So because they're kind of out and about, they may be in other places. And so this is kind of a cartoon of a lymph node. The yellow areas that are labeled follicle, that's where the B cells live. And then there's a vein and an artery and lymphatic vessels that go in and that allow for cells to go in and out of this lymph node to interact with the other cells that are in the lymph node. If we look at non-Hodgkin's lymphomas in general, they're not the most common cancer in the US. They're like number 5 and 6. But we know that the incidence has been increasing in the US since about the 1950s. Some of that has to do with age, that the population just lives longer and older people tend to get more lymphomas. And there's other things that we don't know about that probably contribute to the incidence of lymphomas. So lymphomas in general tend to be found in older people, but there are children that have mycosis fungoides and cutaneous B-cell lymphoma, so it's not just adults. And as I mentioned, in the US, if you just mention lymphoma, people are going to start assuming you're talking about B-cell lymphoma of lymph nodes. That's what they're going to assume, even though the skin is a very kind of popular site for lymphomas to begin. And as I mentioned, the incidence of non-Hodgkin's lymphomas continues to go up in the US, but luckily the mortality has decreased. That means our treatment is getting better and better and better. And that's true for skin lymphomas as well. And as I mentioned, lymphomas happen more in, it says elderly, age 60, so I'm elderly. But when people get older, their immune systems don't function so well. And they get old, the immune system gets old too, and it can't kind of control these errant cells that come about. Whereas when you're younger, maybe one of these cells gets crazy, and then the lymphatic system says no. It's not happening, and kills them. But as we get older, that's less and less apparent. This is 2008 incidence of non-Hodgkin's lymphomas in the US, about 65,000 people, and that continues about the same. And then this is just a fraction of all the different kinds of lymphomas. So we see follicular and diffuse large B-cell lymphoma are the most common. They're B-cell lymphomas. Then you look at peripheral T-cell lymphoma, 6%, and somewhere within that 6% lies things like mycosis fungoides. So it's not very common. Why do people get lymphomas? Everybody always wants to know, why did I get this? Most of the time, we have absolutely no idea. But there are some things we actually do know about. So some lymphomas, not mycosis fungoides, seem to be either caused or stimulated by viruses. So HTLV1, which is on the list here, is a retrovirus like HIV. It is endemic in certain countries. Japan is kind of the poster child, if you will, for HTLV1. And HTLV1 causes T-cell lymphoma. It causes something that looks just like mycosis fungoides, but it's caused by this virus, and you can check in people's blood tests to see if they've had exposure to that virus. Hepatitis C seems to also stimulate lymphoma production. So many people are screened for hepatitis B and C when they get a diagnosis of lymphoma, because we now have treatments for hepatitis B and C, as an example. There are other conditions that might be associated with bacteria. So Lyme disease has an association with slow-growing B-cell lymphomas of the skin, as an example. In general, if you cause something to malfunction in the immune system, either the immune system is being suppressed or it's dysregulated, you will have more lymphomas. So people that have organ transplantation, that are always getting their immune system suppressed, they have more lymphomas. People that have HIV infections, where the HIV suppresses their immune system, they have more lymphomas. Congenital immune deficiencies. Even things like autoimmune diseases like lupus or rheumatoid arthritis are associated with more lymphomas. And then we look at exposures, and really the only exposure that we pretty much know about is Agent Orange, which was utilized in the war in Vietnam. So much so that if somebody was fighting in Vietnam, that the government will give them some money if they have a diagnosis of non-Hodgkin's lymphomas. We don't know about other defoliants or pesticides, but it's something that people are watching. And usually, these are not conditions that are transmitted through families. There are some families that have probably too many lymphomas within them, but we don't really know why that happens. So how does somebody find out they have lymphoma? Either they have a lymph node that they feel, they might have symptoms like a fever that persists for no good reason, very profuse sweating at night so that they're soaking what they're wearing, or a very profound weight loss for no particular reason. And by profound, I mean like 20 pounds for no reason, not like 5 or 10 pounds. They may have other kinds of lumps, like in their skin. They may have abnormal blood counts that are noted, or they may have a skin rash or itching. So this is just an example, since we're going to be talking a lot about T-cell lymphomas of the skin, because that's the most common kind. Of all the different current diagnoses of T-cell lymphomas, the WHO, or World Health Organization, convenes about every 3 years, and they listen to information about what new lymphomas people have discovered or noted, and they change the classification every couple of years. So this is the current one. The next one will be coming out this year, and we'll have some changes in the T-cell list. But you see, it's a long list. Mycosis fungoides and Sézary's is at the top because it's one of the more common ones. And in general, the way this is organized is the ones in white are slow growing and the ones in red are fast growing. So many T-cell lymphomas are not as slow growing as mycosis fungoides. It's an area that's really hard even for oncologists to understand. So I'm just going to show this to you so that you can understand a little bit what you might have, and so that you read about something that relates to you and not the wrong thing. So as I mentioned, there's the umbrella term of non-Hodgkin's lymphoma, and it's 70 plus different conditions. All different either based on the way they show up in a person, something about their pathology, something about their genetics, something unique that would tell a clinician that you would need to do something different for this patient. And the precursor lymphoid neoplasms, they're cells that aren't mature yet. That's the acute leukemias that are T-cell. We're not going to even think about that. The cells that are fairly mature should be functional T lymphocytes. We can roughly divide up all these conditions in terms of where they show up in the person. So some of them show up in the blood, we're calling them leukemic. Some of them show up in lymph nodes. Some of them, extranodal means just something that's not a lymph node, like somebody's nose is the primary site, or somebody's intestines is the primary site, or somebody's fat in their skin is the primary site. And then we have the cutaneous ones, or the skin ones. So you'll see mycosis fungoides, transformed mycosis fungoides, Sézary syndrome, a very large group of disorders called CD30 positive lymphoproliferative disorders listed in that group. And again, these are color-coded. The red ones grow more quickly, the white ones grow more slowly. And then this is just a list, a very small list of the types of skin lymphomas that we see that are B cells. The actual list of B cell lymphomas is a great deal longer. But primarily, there are two varieties of slow-growing B cell lymphomas of the skin. They have names that are the same as the node kind, so we have to be very careful that we understand that they may be different conditions. They may differ pathologically. They may differ in the way they behave. They may differ in their treatment. And then we have two of them that grow more quickly. One is called diffuse large B-cell lymphoma leg type, and one is called diffuse large B-cell lymphoma intravascular. It means the cells are actually in the blood vessels. So I'll finish kind of as an introduction. Why are we talking just about skin lymphomas? Skin lymphomas are really different in addition to being in somebody's skin. So for one thing, we're mainly dealing with T-cell lymphomas, which is uncommon. So most oncologists don't have very many patients with T-cell lymphomas because A, lymphoma is not so common, and B, in this country they're going to be B-cell lymphomas. But when we look at just skin lymphomas, T-cell lymphomas become very common. And as I mentioned, some of the names that were given, mycosis fungoides isn't an example of this, but some of the names that were given are very similar to diseases that are in lymph nodes. But the behavior and the treatment is going to be very, very different. So skin lymphomas have their own classification and their own staging systems that are different from other non-Hodgkin's lymphoma for that reason. And it's unfortunate that they picked the same names, but it has to do with anatomic terms like follicles and things like that. So we have to be sure that when we're reading about skin lymphomas, that we're reading just about that lymphoma, that we're not getting confused about the staging and applying nodal staging to our condition. We're not looking at the treatments, which may be very, very different. And I have two pathologists here, so I'll apologize for saying this, but it's the truth. Unlike other malignancies like breast cancer as an example, when a pathologist makes a diagnosis of lymphoma in general or skin lymphoma, it's usually not a kind of diagnosis where everybody says, yes, it has to be that. There's a cooperation that has to exist between the clinician and the pathologist because the clinician actually sees the person. And the best example I can give of that is CD30 positive lymphoproliferative disorders. So some of you might know, one of them is called lymphomatoid papulosis. One of them is called primary cutaneous anaplastic large cell. When a pathologist looks at that, they really don't know whether the disease is coming from inside of the person from their lymph nodes or whether it's just on their skin. And those two disorders actually can look pretty similar under a microscope. So it's really important that the person seeing the patient understands what they're looking at and can kind of mesh that with what the pathologist sees under a microscope to arrive at a final diagnosis that will allow them to have a working diagnosis and a treatment, involve a treatment for a patient. And as I mentioned before, people with skin lymphomas really may use a team of doctors. I mentioned pathologists. We can't do anything without pathologists, skin pathologists and nodal pathologists. We absolutely have to work with them. Oncologists may play a role, particularly those that are interested in this. I'm an oncologist, but I do a lot of work with skin lymphomas. We may also work with a dermatologist. Dr. Linden hopefully will get here. He's at a melanoma event this morning. He's going to get here and talk to you about what the dermatologist's role might often be. So we might not all be in the same place physically, but we're all working together all the time. And that's probably true at any institution that's interested in skin lymphomas. There has to be a group of people that work together.